Welcome back, everyone. That was a report on endoscopic surgery, and with us to talk about this, we have our second guest this evening, Dr. Ismail Al-Badawi, consultant gynecologist and oncologist and minimal invasive surgeon. Welcome, Dr. Ismail. Thank you for being with us in the program.
Thank you very much. Thank you. Welcome.
Thank you very much. So first of all, Doctor, if you could tell us what is endoscopy?
Sure. Endoscopy is a very general term. Endoscopy meaning you're using a camera and going inside any part of the body. That's mean endoscopy, inside, and checking organs for diseases. So, for example, you can check the stomach by doing endoscopy through the mouth. You can do bronchoscopy or so, like going through the nose. You can do colonoscopy, going through the colon. And for gynecology, what is my specialty is, you can go through the abdomen to check and do surgeries inside the abdomen without having to cut the patient open. And that have got so many advantages. And another one, if there is cervical cancer, or cervical problem, or gynae problem, instead of doing the common gynecological examination, there is a special endoscope called colposcopy, where it's done in the clinic without anesthesia, without anything, and you can just do it immediately, and you can diagnose so many diseases on the spot. Yeah.
Interesting. And this has been, it seems, so you do a surgery inside the body without actually...
Let us simplify it. We call it the keyhole surgery.
Okay.
Basically, instead of making a big incision, we used to make a couple of small holes between 1 centimeter to a ½ centimeter, and really ½ centimeter because the instrument goes through a ½ centimeter, 1 centimeter.
Right, ½ centimeter, you're talking about the diameter or?
Diameter, yeah. Diameter.
Just a small one hole or a few holes?
Okay, this is an excellent question. Till 1 year ago, when you talk about laparoscopy, which is the form of endoscopy where you do the surgery, it's usually many holes, about 3 to 4 holes. Recently, now, what we are doing is doing the whole surgery from one hole. It's just making an incision in the belly button, in the umbilicus, 1.5 or 2 centimeter now, and you can do the whole surgery through one hole, which is 1.5 to 2 centimeter. And it's hardly can be seen because it's done in the belly button, in the umbilicus. Yeah.
And how? How is it done?
This is
robotics? Or?
Okay, excellent. Now, we went through evolution in medicine, like everything else. Like teaching medicine went through evolution from sitting in classrooms into doing through telemedicine. The same happened in the operating room, from big incisions to multiple hole surgeries to robotic, where you do the incisions and you sit on a robot, you operate a robot from the same room or from a different room, so you can do surgery from a different city. Till now, we are doing instead of having a couple of holes through one hole. How we do this? We make an incision, 1.5 or 2 centimeter incision, and we put a special device. We insert it through the umbilicus, and through this special device, we can put 3 or 4 equipments. One of them is the camera, and you can put scissors, graspers, something, and you can cut and remove, and you can remove the bad, diseased organ through it, or you can make it diagnostic, or you can do any form of treatment. And this single hole, you can do it either by the robot or by the common laparoscope with some special equipment and some special training. But at the end of the day, the patient can leave the hospital after a few hours, pain-free, cosmetically nice, and you can hardly tell they had surgery through the umbilical, because there's going to be no scar, practically speaking.
And no pain, right?
Amazing.
And no pain, because the umbilicus is very thin. It doesn't cause too much pain to go through it. So, yeah.
But you're removing something, so that thing is it always smaller than that hole? What if it's bigger than the hole?
I really love the questions here. Actually, sometimes the common thing is ovarian masses, ovarian cysts. The ovaries sometimes get some cysts, tumors, and these cysts, you can put it inside a bag, inside the abdomen, aspirate the fluid, and then bring it through the same hole.
Okay.
Or you can do hysterectomy, remove the woman's womb, remove the uterus. And you cut everything from outside, and you just pull it from below, like delivering a baby.
Okay.
Wow.
And you can do it routinely. And you can do even not only general surgeries like removing a fibroid or a cyst, you can even do it for cancer cases. So instead of, and what's the advantage behind that? You can do the whole cancer surgery, and the patient doesn't have to go through a misery of big incision in addition to her cancer diagnosis. And more important, she can start her extra treatment like chemotherapy or radiation very soon after the surgery, because she wouldn't need time to recuperate or recover.
All right.
Yeah. Well, doctor, this is certainly you've made it sound like there is no end of possibilities for endoscopic surgery. But now we're going to go for a short report, and then we'll be back to continue talking about the subject. So stay tuned.
Welcome to Springfield Clinic's Ambulatory Surgery and Endoscopy Center. Your first stop is the check-in counter. They will ask your name, which doctor you are seeing, and what procedure you are having done, and basic information like your address, phone number, date of birth, emergency contact, and insurance information. You will then be sent to the information desk, where your family will receive a pager to alert them when you are out of your procedure and in the recovery room. The information concierge will confirm that you have a ride home from your procedure if you are having any type of anesthesia. After a brief stay in the waiting area, a nurse will take you for some standard medical checks, such as weight and temperature. A urine sample may be taken. A family member may accompany you to the room. The nurse will take your blood pressure, pulse, and respiration, then go over some important information, such as if you've taken aspirin lately, if you have heart disease or diabetes, if you have any restricted movements, any previous surgeries, and a phone number at which you can be reached post-operatively. The nurse will also ask if you have any dentures or false teeth. These may need to be removed, as will any and all jewelry and glasses. You will then sign a consent form to confirm your procedure. On this form, you will also indicate your hospital preference, which is important for those rare circumstances in which we would need to move you to one of the hospitals. Depending on your procedure, you may be asked to remove all clothing. You'll be given a gown, a surgical cap, and a pair of slip-resistant socks. Once changed, you will be given a warm blanket as your IV is placed and fluids are administered. If you require more than IV conscious sedation, your next visitor will be your anesthesiologist. He will ask when you last ate or drank, if you have any major medical problems like asthma, heart problems, or if you have a history of anesthesia-related complications. Then describe the anesthetic plan for your procedure. You will walk into the procedure room if able. The staff will help you get comfortable and positioned for your procedure. At this point, sedation will be administered and the area will be prepped. Anesthesia or sedation will be administered intravenously by a registered nurse or a certified registered nurse anesthetist. After the procedure, your doctor will visit with your family, update them on your condition, and let them know how soon they may see you. After your procedure, you will wake up in recovery. Generally, you will remain in recovery for about 30 minutes to an hour. Once you're fully awake, the nurse will give you something to eat and drink, administer any pain medications you might need, and invite a family member to join you. If the patient is a child, both parents may enter the recovery area. The recovery nurse will go over your post-operative instructions. These include the different ways to take care of the area on which the procedure was performed, as well as when to begin physical activity, what kinds of food to eat after your procedure, and which medications to avoid for the time being. After these instructions, you will be able to get dressed and be discharged. Then your family member can take you home.
Welcome back, everyone. And of course, that was another report on endoscopic surgery. And with us, to continue discussing this, we have Dr. Ismail Al-Badawi. consultant gynecologist, oncologist, and minimal invasive surgeon. Welcome back, Dr. Ismail.
Thank you very much.
Yes, thank you for being with us again. So, Dr. Ismail, before the break, we were talking about all the pros of endoscopic surgery.
Sure.
And I would like to ask you now, what about what are the risks
Sure.
with endoscopic
very
surgery?
good question.
Yeah.
People always like to think about the risks of endoscopic surgery simply because it's newer, not very commonly used. But the risks of doing surgery through the endoscope or the laparoscope is exactly the risks of doing it in open surgery. So when you do major abdominal surgery and you are having a risk of injuring other organs, risk of bleeding, risk of having a clot, blood clot, the same risk goes with both open surgery and laparoscopic surgery. And you'd be surprised, with laparoscopic surgery the risk is less because you're using smaller equipment and you're seeing clearer, more direct vision by the laparoscope. But people tend to think of it as something newer, so it might be associated with more risks, but the risks are exactly the same. And the opposite, things like anesthesia or having a blood clot from a major surgery, it's more with big scar incisions because simply they lie down, they don't move, so they are more liable to having a blood clot. They stay in the hospital longer, so they might get an infection just being in the hospital. And they use more strong painkillers, which makes them walk less and use Foley's catheters more, so they are more prone for infections and clots. Bleeding and injuring organs is exactly the same. The important thing is that the person the physician using the laparoscopy knows how to use it, and the same applies for open surgery. The person who's doing surgery should know how to do it and then would avoid the complications. It would happen anyway in a small percentage of time, which needs to be included in the informed consent before the procedure, before the surgery, which should discuss the risks and benefits for all the options. And then tailor your recommendation, whether laparoscopy or open surgery, depending on what the patient have. If she has something amenable for laparoscopy or keyhole incision, better off to do it because she can go home the next day. She would go back quicker to work. She would use less painkillers. But if it's not doable, just don't take the risk and do it as an open case.
Can we have if you can give us like a case example of how you would take the condition and then say we'll go with endoscopy or we'll go with open.
Can I share with you the discussion I had this afternoon with my patient who got admitted today for surgery tomorrow morning at 7:30 in the morning, without mentioning names, without mentioning places or anything. Basically, this patient had an ovarian mass. This mass is solid, it's not cystic, has been growing. So this is a clear indication she would need to go to the OR to have it removed, to make sure it's not cancer.
Sure.
To improve her symptoms. So I sat with her today and discussed the options with her. Now you have got something there which is supposed not to be there. So we need to remove it, to cure it and to diagnose it, to make sure you don't have something cancerous. The problem, your best option is to go by laparoscopy. Make a small incision and remove it, and you're able to go home the next day. But the problem is, this mass is solid. So it's not going to be easy to go out from a 1 centimeter, 2 centimeter incision. So what we're going to do, we're going to go it in, and if we think we can remove it by the laparoscope, we'll remove it. Otherwise, we're going to make an incision open. But at least you have a 50% chance for having it by laparoscopy. If you get it by laparoscopy, you'll go home the next day, you'll be able to discharge, you're going to have less pain. At the same time, after we remove it, we're going to send it for what's called frozen section, meaning checking if there is any cancer cells immediately while she's asleep. If it is benign, we'll just finish it by laparoscope. If it is not, we have to cut you open to remove your uterus and to take a couple of biopsies. And then you're going to stay in the hospital for 5 or 6 days. She was happy that having both options, that we're not going to take any risks by just risking her doing it without properly being prepared. And she has a chance, at least 50% chance, to have it by the laparoscope and being able to go back home soon. She was not there alone. She shared the decision with her husband and her 2 daughters, and they discussed it and they were happy with this plan. Putting in mind the risks, there is risk of anesthesia, and she was cleared for that. Risk of bleeding in both situations, and we might give her blood transfusion if she needs blood transfusion, and we'll give her a blood thinner to prevent DVT or clots, blood clots, and we're gonna make sure to recognize if there is any injury to other organs to repair it immediately. And that's how it went.
That's how you decided.
Yeah.
Well, now, okay, the difference between, again, the endoscopic surgery or making an incision, for the surgeon, does it make a difference for you in terms of the time and the effort? Because, okay, you save time, you've removed the anesthesia, you don't have to make an incision, so that means you don't have to go stitching afterwards.
Sure.
But with the laparoscopic instruments, does that take you more time to do the work? Does it get more complicated, and does the time get more?
There is what is called learning curve. At the beginning, it's more difficult, more challenging.
Yeah.
And even to be accepted by patient is something, and to be accepted by colleagues is something else, because people are very resistant to change. They don't want to change. They have been doing it by open surgery for many times. They don't want to do something different. It takes them to adapt it. So there is a learning curve. You have to do it, and then to teach the people around you to create the culture.
Yeah.
At the beginning, it takes some time, but like everything else, once you are good at it, the timing it takes is less than open surgery, because you don't need to stitch back a big incision. You don't have to make a big cut. So once you're comfortable with it, it's going to be the same. But you have to tailor it. Not every patient is the same.
Of course.
Definitely. So who would you say, as you were just mentioning that lady, obviously you gave her both different options, and obviously the option that you gave her was, it's a win-win situation in her case. But in other cases, who would you say that endoscopic surgery is beneficial for, generally speaking?
Generally speaking, if you can do it laparoscopically, you should do it laparoscopically.
You should.
You should. Because basically, who would want a big incision? Who wants to stay in the hospital for 7 days and recuperate in 6 weeks?
Yes. Yes.
If you have the chance, if there's any chance or possibility, you should do it laparoscopically or endoscopically.
You can only eat so much chocolate and have so many roses.
Absolutely, absolutely.
Let me ask you this: is there any difference in terms of financially? Is it cheaper or more expensive to do it laparoscopically?
Excellent question. Actually, let us look at it individually and then as a whole. Individually, it's more expensive during the operation time because you are using disposable instruments, expensive instruments, which is laparoscopic instruments. But you save money by sending them home the next day. You don't stay in the hospital for 7 days. So if they stay in the hospital for longer days, they pay more for the beds, and you care for less number of patients. Because if one patient occupies the bed for 7 days, it's different than 5 patients occupying the same bed for 7 days. So you save money on sending them home early. But don't do laparoscopy and keep the patient for a week, and then you haven't done much.
Sure.
And with time, initially, the laparoscopic instruments were more expensive. With time, the companies were able to bring their prices down when more and more surgeries being done. And we have a very good example, which is this single incision laparoscopic surgery. The device, a year ago, used to cost the device, you need a kit or a device to use it, used to cost about 5,000 riyals per device. Now it's 2,500 because they're selling more.
Right, yes.
And the patency rights are getting less. So.
Sounds very... when you were going to say the price, I was expecting 70,000, 80,000,
wow.
90,000.
No.
Even though you said kit, but...
It's okay.
Well, Dr. Ismail Badawi, I'd like to thank you very much for joining us on the program and sharing with us this information on endoscopic surgeries.
Thank you very much. I appreciate it.
Very enlightening.
That was our guest, Dr. Ismail Al-Badawi, a consultant gynecological oncologist and minimal invasive surgeon. And I'd like to leave it to Camille to wrap up. Camille?
Okay, well, and so thanks again to Dr. Ismail, and from myself and from Waleed and from our director, Fahad, we'd like to say thank you, and everybody here on Harmony of Life, we'd like to say thank you very much for joining us this evening. We hope you enjoyed our topics. We had Dr. Yasmin and we had Dr. Malia talking about teeth whitening, and of course we had Dr. Ismail talking about endoscopy and endoscopic surgery. And now we are going to say good night, and until tomorrow, assalamu alaikum. Take care of yourselves, take care of each other. Good night.
conosci il tempo delle te